Here we present the endovascular management of an acute basilar artery occlusion with mechanical thrombectomy. The patient is an 82-year-old female who was brought to the emergency room after she was found unconscious. On examination, she wasn't responsive with the eyes closed. Pupils were symmetric but very sluggishly reactive to light. She had also 6-nerve palsy and was localized into pain. Her initial NH score was 21. She had past medical history of atrial fibrillation. However, she had recently stopped Coumadin due to a hip fracture that required surgery. Patient received TPA with no improvement. CT was normal. However, CT angiography and CT perfusion demonstrate complete occlusion of the basilar artery and a significant increased time to peak in the posterior circulation with very well preserved volume. The patient was transferred immediately for endovascular procedure. Under conscious sedation and through a right transfemoral artery approach, we obtain access into the left subclavian artery with a 6-French catheter, from there into the left vertebral artery. From there we maneuver a reperfusion catheter, a microcatheter and microwire. We were able to navigate into the basilar artery with no problem with the microwire and microcatheter. And we also advanced the reperfusion catheter into the distal segment of the vertebral artery. We crossed the thrombus in the basilar artery, and we also deployed the stent retriever, as you can observe in this picture right here. We are unsheathing the microcatheter while we're pushing the stent retriever in such a way that the stent retriever is deployed from the posterior cerebral artery down into the basilar artery. After waiting about 4 or 5 minutes, the stent retriever is pulled and we observe no reperfusion yet. Similarly, we again advance the microcatheter into the left posterior cerebral artery, deploy the stent retriever, wait 4 to 5 minutes for the thrombus to incorporate with the stent retriever, and under aspiration we remove the stent retriever. We have successfully opened the superior cerebellar arteries, but still the main trunk of the basilar artery was still occluded. We then again maneuver the microcatheter further distal into the right posterior cerebral artery, deploy a different stent retriever from a different brand, but we also advanced more the reperfusion catheter, and I think that was the key to the successful revascularization that you're going to see here next. You see how the reperfusion catheter is really advanced almost into the posterior cerebral artery, and then everything is pulled out under aspiration, and you can observe complete revascularization of the basilar artery. Thank you.